So for those of you who are familiar with this section, we've got a generous amount of time until about 12:20. So or we can finish early, but that hasn't happened yet. As I was just saying to Jerry, every year we say, this was the best one yet. And I think it was. So thank you for you guys. You know, Lee was talking about how many research groups we have, and every year it's like going to a gallery where you can take anything home you want, but only 3 or 4 of them. So each year, just finding all of the masters to bring down to talk is a challenge and a pleasure. So stay tuned. Anyway, this is a time where if you have a question, I'll be looking out and trying to pick in front and in back, and we've got roving microphones, and we've got, by the way, everybody of our staff who's carrying a microphone themselves are competing for my attention. So I love both of you guys, okay, but we got to go back and forth. Miranda?
One of the unbelievable wonderful privileges of being associated with MGH through the years on the Leadership Council is that one has friends that call and ask. My latest is a family. This is a grandson who is a transitional, adult and is in Connecticut. Can you address the issue if this is a grandchild of people who live in Palm Beach. They are not from Boston, and this is a Connecticut situation. Can MGH help this family?
So what do we do with our network or local or come into town? Tim?
So a lot of that, depends on do the individuals have the means to be able to come up to MGH and potentially see one of our clinicians or one of our individuals who's in private practice. We have faculty who have private practices. And then we also, and the answer is, if they can, we can work out an arrangement. We can also have them come to our transitional age youth clinic, this special clinic, to at least get a good diagnostic workup and then sometimes some stabilization and then referral back to their either local prescriber or to other individuals around that might be willing to work with them. And then other times I've talked to a number of people here about knowing the programs that we're affiliated with, like McLean Hospital has certain special programming for transitional age youth, for example, that works, and concert with working with us. And then sometimes in a less frequent thing, we can put together a team of people, and actually Christina's been involved with that with different individuals, where we can sort of do a case conference, meet with them, or have a couple of people meet with them, and organize that so they get a couple of opinions when they're up in Boston. We can help set up a treatment plan. So there's a lot of hope, and I want to underscore what Christina said about, there's nothing you can do. I find that just viscerally not acceptable when I hear that. There's a lot you can do for people, and sometimes it's just getting a different set of eyes to look at them.
So Miranda, it's such a critical question because in a way, it can also be a little frustrating. We come down here, we talk about our programs, but a lot of people won't make it necessarily to get up to MGH. Because I think your question, the larger question that you also ask is, what do those people do? And how can we be of help? And I think Maurizio and I and the other leadership in the department is very committed in mobilizing the extensive network of very capable colleagues around the country with whom we can work, to whom we can refer, and with whom we can collaborate, perhaps even sort of serve as a little bit of a quarterback in these very complicated cases so that they're not alone. So as Tim mentioned, sometimes patients will come up to MGH, particularly if it's a very complicated case for a consultation. But I think your question really went to, and then what? And I think that establishing appropriate referrals to people that we trust, our trainees, our colleagues, I think it goes a long way. And then staying connected to those situations clinically over time.
And another point on that is I often, all of us, get these calls and from somebody who has a relative in Cleveland. And the question is, can you recommend a psychiatrist in Cleveland? Well, that is inadequate information. So what happens is trying to get closer and closer to the person, finding out specifically what the problem is so that we can direct it specifically to where there may be a solution. So if you have a relative in Boulder and you get the name of somebody, you're just taking a shot in the dark of that you're going to get the right kind of care. So more details.
And the other comment I would just have is sometimes all people really want is to have a phone call and say, they're using this, this, and this. Does that seem reasonable? And oftentimes we can say, yeah, that's an entirely reasonable thing. What are they doing for Plan B and Plan C? And I hear that, and there have been a few people I'm looking around here that I've had those conversations in the last month or so. And they just want reassurance that this is the right treatment plan. And that's not a tough, heavy lift for us, and it really reassures the people on the other side.
Where are we? Michelle. Okay, yes.
So this is for Tim or anybody else, right?
You're second. Michelle, you're first. That's why I have this job.
John is so smart. This will be for Tim or anybody, but it seems like there is more anxiety among young people in particular. And is that because of the world we live in, or are you just diagnosing it earlier?
So certainly we have Jerry. I'd be interested in Jerry's reflection on that because he's always been a believer in terms of the anxiety onset in childhood. So the data would show that actually the epidemiology of that is that it's been there for a long time. We're just recognizing it. And then there's, we call interaction. That is the environment by what's already there. And you're seeing it exacerbated because of the environment. So the levels are the same, but the amount of distress in our country versus other countries is very much higher. Our kids really have more stress and duress and suffering associated with some anxiety. And that is, again, a pitch for why we are so now very involved in very early identification and treatment. We had, through philanthropy, actually studying 2, 3, and 4-year-olds to pick up very early anxiety to see, can we do an intervention with the parent and the kid that'll mitigate the ultimate risk for anxiety over time. The answer, by the way, the preliminary data is does. It actually does. It actually helps keep that down. So this is, again, one of the reasons that we're really interested, and we have some philanthropy. Some people want to do app development. We're looking for somebody who might be interested to match that and help us do that so that all kids can have something. But it does go to the heart of this sort of intense interaction. We're going to be talking more about resilience on June 1st, just as a pitch for the visiting day. Everybody was invited, right? Well, they just were. So if they weren't, you are now. Exactly. And we're going to be, one of the programs, we're going to be talking about some of the work that we're doing and some of the very interesting early things that we're just kind of launching now from that program. But it's really, it's a critical area right now.
All right, Laura. Laura Carney's up next. Oh, did you have a comment on that?
Yeah, no, a comment because
Laura,
I think
I promise you'll come next.
So it's a great question because one of the things that we do see is an increase in the rates of depression with every decade. So the younger you are, the more likely you are of being a risk for depression. And depression, half of the time, is associated with anxiety. And sometimes anxiety is an early sign of depression. In some ways precedes the onset of depression. So I think that what you're describing, I certainly see it, that the number of calls that I've been getting from friends, colleagues, noticing their child is getting anxious, depressed, is clearly increasing tremendously. So I think it's an epidemic that it's kind of spreading, and in my mind, that's why we're seeing the vaping. That this is self-medication, in my opinion. We're seeing the distress and people trying to relieve their distress with substance use. So I think that we have a big problem, and it's not, we're not equipped, in terms of our ability to provide access. We're not there yet, but we have to get there.
Okay.
You've answered all my questions.
Good. Hey, over there. Yeah.
Hello. I have a close friend of mine who's been struggling with depression for years, and he's described his course of medication. Started with one pill, and then they tweak it with another pill. Doesn't work as well. He gets better for a while, then down, another pill, and now he's taking 7 or 8 pills, I don't know how many, every day. I just texted him, I said, hey, what about ketamine? And he said that he tried it a year and a half ago, and sadly, he was in the 50% of people that it didn't work. Can you speak to the interaction between ketamine versus the antidepressants? Does one have to be free of antidepressants and try it alone, or do they work on top of the antidepressants? Can you speak about that?
Based on the initial trials, all the patients were so sick they could not stop. So we had to give ketamine on top of other antidepressants. And when ketamine was working together with the combinations that were a little far out the left field, like we're talking 2-3 antidepressants plus augmentations plus something else, adding the ketamine brought them to level of much improved. Everybody tried to peel off some of the other medications underneath and said, the ketamine is going to replace. No, it was a disaster. They relapsed. So we had to put back everything that was there that was providing a little bit of cushion and use the ketamine to have the last, there is an additive effect. So the ketamine provided the last additional piece to bring the quality of life to a decent level. But every time they tried to take off something else, they would relapse. Again, those are patients in the extreme, really extreme forms, the sickest patients I've ever seen in my 20 years of practice, so that are really the 2%, the 1% of the curve. But in general, removing the antidepressant under the ketamine is not a good idea.
Just a quick follow-up. What happens if a non-depressed person takes ketamine? what does
You
that
get
feel
high.
like?
You get high for a few hours.
My question is for Dr. Evans. I was wondering, with vaping, what types of medications or treatments are they using to try to help kids?
So this is a fantastic question. Again, this is a problem that did not exist 3 years ago and really has only come into the forefront now. The first RFA, request for proposals to develop new treatments, came out not from the federal government, came in November from the American Heart Association. We have a meeting Monday and Tuesday at NIH. I'll be there, a small meeting to try to understand priorities and decide what are the first treatments to test. So right now, we at Mass General have been treating kids and also working with our friends and colleagues at Children's Hospital to test just not in a clinical trial, but to treat a series of people. We've in Children's Hospital, they're using nicotine replacement therapy, so patch or gum or lozenge or the combination. We have been using both. We use patch and gum and also varenicline. We've had about a 25% success rate with the patch and gum and about 75%. Varenicline is Chantix, so it's the most effective medicine for smoking cessation. So this is for nicotine dependence. So it makes sense it would work if you are nicotine dependent, have a dependence on the substance, whether it's from smoking or from vaping. The challenge is what's going to work in kids, because interestingly, these medicines don't work as well in kids as they do in adults. And that may have to do with motivation to quit, right? Or belief that this is harming you. So great question. Please stay tuned.
A follow-up, yes.
One of the things, I happen to have children in the 18 to 22 range with wide open frontal lobes. And one of the things with vaping is they talk about not doing the flavored vaping, so the mango, the that the chemicals in that is what's so dangerous. So if you take that out, it's okay to vape. That it's not, what they're hearing is it's not the vitamin E acetate, but the flavoring.
Yeah. It's a great question. So there's several things, right? So there's the flavoring, there's the liquid that makes the vapor and makes it of a consistency that'll actually make a vapor, so the chemicals, and then there's the addictive substance that's in it, so the nicotine or the THC. So all three are important components. And then one thing that we're needing to do is to try to educate, and what we want to do in the schools and are developing, like literally right now, an intervention in the schools to educate kids, teachers, parents about that there are the three components, right? And we don't know what's going to happen. We're going to be flavor-free very soon. Massachusetts is already flavor-free. Unfortunately, we're seeing some kids who are addicted to vapes. Once there's no flavors and they've lowered the nicotine content in the vapes, they're starting to smoke. So something that we had really almost won that battle, right? Fewer than 2% of kids are current smokers in our high school surveys.
So Tim's going to say something, but I thought that one thing you might offer, is it your son? That they could share with us their peer-reviewed publications on this issue and their scientific work, because we could integrate that into our work as well.
They do actually. They take you to websites.
Well, it's actually true, because we would need to know kids' impressions in order to be able to craft the right message in the school. So actually, I would love to hear what the kids, maybe after the seminar.
The only other comment I was going to have about nicotine exposure in kids is that a number of years ago we showed that it really increases the likelihood to have a substance use disorder later. And if you give, for example, rat pups subcutaneous nicotine, just give them a shot under their skin, and then you look at those rat pups later as they grow up into adult rats, it's much easier to teach them to self-administer cocaine and other drugs, which is a model they use for substance use. So it used to always be thought of it's nicotine exposure. It's actually the kids. It's more sort of socially driven. But nicotine really creates a lot of plasticity in the brain, and in this case, it really increases the likelihood for later substance use. That is a very scary thought, given the delivery systems and the potency of the nicotine that kids are vaping.
We often say you don't think that cocaine needs a lot of help being addictive, but nicotine increases addictiveness of cocaine.
Yes, this question is regarding dementia to Dr. Gachel. Can aerobic exercise, for example, help to prevent or reduce the possibility of the protein buildup you were suggesting to try to prevent or not accelerate getting dementia?
Yes, that's a great question. I'm glad that you brought that up. And one thing I didn't have a chance to touch upon in the slides or go over in great detail are just kind of the lifestyle interventions that we're as a field are developing increasing data on that could be protective to potentially slow dementia. And one of the key things that the most robust evidence that we have thus far is on exercise or physical activity. We know that exercise seems to be beneficial in preventing depression or having antidepressant properties, and also in promoting positive cognitive health. And then there are increasing data that even increasing physical activity by number of steps, by wearing a pedometer, that's associated with decreased buildup of brain protein. So some preliminary data that it may be even protective at that molecular level in terms of protein deposits. So it's still very early in terms of that research, in terms of what type of physical activity, how frequent, aerobic or strength exercise, and could it really be preventative in combination with other therapies. So it's not a definitive cure or treatment, but it's something that I always recommend to patients and can certainly be protective for your overall brain health. But always do it in conjunction with a medical provider in terms of starting a physical activity program that's safe for you in terms of your overall medical conditions.
First of all, I'm back again, and I think this is an incredible day. And the outreach is the motto where no family goes untouched. But I had to make a phone call because in a tough situation. And I just can't thank Dr. Rosenbaum for being there. And just having somebody there is it's incredible. So thank you. In terms of mental disease, where are we? Actually, you mentioned about blood in PET scans. we get a blood pressure, we see per high or low, we diagnose. Comments about blood?
Jerry. The question is partly directed because you've been so helpful, but it's a larger scope question I think you're asking, which is where are we at? Where can we hope to be going? What test? Blood is only one of it. What's the horizon look like?
Yeah, well, I'll introduce the topic and let Maurizio continue it, because it's the advance in this area that we call precision psychiatry. That's a big part of my successor's vision for where we go next in the department. And it has to do with the incredible explosion of new ways to interrogate the brain that has been so difficult for psychiatrists, because as you heard earlier, we can't take a piece of your brain and understand exactly what your pathology is. But now we have an array of tools, really advanced neuroimaging. We have genetic risk profiling. We have AI that allows us to gather incredible amounts of data that make predictions. We're getting better at differentiating among a population that we treat as if they're homogeneous, but they're really, each individual is unique, and that we are developing an array of assessments and biomarkers that will lead us to be able to know what we have to do to treat you. Now, the other part of this story is that we have to have the treatments that are so specific that we can deliver them to you, and that's the other part of the challenge for the next decade, is developing the new generation of treatments. And I can tell you that that's underway, that there are efforts to look at innovative targets and new molecular entities. And even the story we just heard about ketamine, ketamine's been around a long time. It was an anesthetic, it was a party drug, it was a substance of abuse, it was a scheduled drug you couldn't give. And now we can look into that world of similar compounds that have enormous effects on the brain, that are innovative and different, that seem to open windows of possibility, like the psychedelics. And if we understand what they're doing to the brain, we might be able to develop new therapies that create treatments that we had not even imagined until recently.
So I completely agree with Jerry. Jerry, by the way, is leading an effort to develop a center specifically for new uses of psychedelic drugs, given the effects on brain plasticity and so forth. And we're very excited about his work that he's going to be kind of leading. But I think fundamentally, one of the reasons why I think when it comes to mental illness, we have neglected mental illness for decades, for a very long time, partly because of the skepticism. We will never, neglect a heart attack. We will never neglect other medical conditions the way we have neglected underpaid, undercompensated, all the prior practice that you hear about is because the reimbursements are so low for mental health professionals and so forth. It's because of the diagnosis. Is it really a disorder? Yes, it is a brain disorder. And brain ways of assessing brain functioning through blood tests, through neuroimaging, will help us say and demonstrate to insurance companies, to payers, look, you can't neglect this. This is a real thing. And we have the test to prove it, and we have the test to match, the Center for Precision Psychiatry that we're establishing with the leadership of Jordan Smoller, I think will be a beacon to show the world that we have real diseases, brain disorders. We can diagnose them objectively, and we're going to match the best treatments to each diagnosis.
So, and I want to get a piece in about, it strikes me that as you're seeing and listening to the speakers talk about their expertise, talk about the front edges of science and the discovery of new treatments, sometimes I think about the supply line, which is we're way out here in front, but as all of you know, and we've talked about this about if you're in Cleveland, or if you're in Boulder, or if you're somewhere else who doesn't know about these, or who can't deliver these things. One of the things we talk about, even within our own department, within our own hospital, is the difficulty of getting access to those who you see here on the stage. So I see, because my interest is in public policy and service delivery, that the frustration is, as much as we're learning, we have a great frustration in the pipeline of future clinicians, practitioners who can adopt this. And I think that that's as challenging as our efforts to break through scientifically.
That's a great point, John. And there are fewer psychiatrists, people, medical doctors going into psychiatry than psychiatrists retiring from the practice. So we're going to have a shortage. And partly it's a very simple economic. The average amount of debt of a medical student is $250,000. And psychiatry is the least compensated specialty. So people will say, why should I go into psychiatry and basically be poor or struggle financially? So we have to change that, and thank God, John is really working on trying to change things in terms of policy, but it's unacceptable.
Yeah, I just wanted to address one point that you made about, I mentioned the amyloid blood test, or that may be on the horizon. So I think we're probably, looking at 3 to 5 years out where that may be something that can be ordered clinically. So right now, amyloid PET scans, although they're not part of routine workups for dementia, they are available for clinical diagnostic workup, and I think we're probably 3 to 5 years out of being able to reliably measure amyloid in the blood, and that's something that could be available clinically. The question is, as Maurizio mentioned, as Jerry mentioned, what does that mean in combination of other biomarkers in the blood or other biological contexts? So what that positive test will mean for prognosis of developing dementia or other conditions is something that we still need more research in that area.
I missed this one. Here we go.
But this was actually a follow-up, but I had to...
Go ahead and follow up.
Okay, this was a follow-up to the, the blood test, the PET scans, the different things. And I thought about this immediately when one of you said, a PET scan's $5,000. I mean, why is a PET scan $5,000 when, these processes have been along for a little while? I mean, does the cost going to come down for that? And, I mean, how much does that impede your research if every single patient that you've got to do a scan on is $5,000 in each time?
Yeah.
PET scans are unique.
So
go ahead.
So PET scans are unique in that you need you have to have the radioisotope. So we didn't go into some of the kind of mechanics or details behind it, but in order to recognize proteins in the brain and visualize those, we use small amounts of radioactive dye that's attached to something that will latch onto that protein deposit. So that has to be synthesized either in-house or close by. So,
It's different. The isotope has to be made by a
a radio technician and a cyclotron. So that's different than kind of what is used for like a CT scan. So there's that aspect to it, and there's kind of also just the cost involved in generating that specific
Not
probe.
everybody has a cyclotron in their backyard.
I was thinking about that slide that you have, which shows X-ray. It'd be interesting what the cost is of each of those along the line.
X-rays are very cheap, but PET scans. But yeah, it does significantly present. It's a barrier to we have to budget for that in grants. So these grants will be like multi-million-dollar grants to be able to scan 300 individuals serially with these PET scans. So that is a major barrier, but at the same time, I think the field is recognizing with the crisis of Alzheimer's disease, with these other mental illnesses, kind of the need to have that information to be able to better treat them and prevent them.
And sometimes the information that we glean then introduces the possibility of much less expensive indicators. But first, we've got to do the discovery, which is where we're at. Mrs. Mahoney?
My question is to Dr. Evans. With all of the CBD that you see advertised all over the place, how do you make an educated guess, I guess, to get the right kind that it's not bad or it's not, which is the best Is there such a thing?
We got PBS watching us now, so.
Hilly, I wish I had the right answer for you. We do not know. We have a large study right now of people who chose to go into the market and purchase CBD for a variety of problems, insomnia, anxiety, depression, pain. And most of those people are getting CBD into their system, but 1/3 have not. And so we have collected some information about what brands, but the brands change, so it's difficult to know. There is FDA-approved Epidiolex. It's quite expensive, and it's not covered by insurance. It's called Epidiolex, so that you do know the concentration. What is out there? I hope that there will be standardization. I hope that there will be testing, and there may be people in this room who know better than I which brands are sort of have been tested, and you can trust what's on the label is what's in the bottle, which is what will go in your body.
Wonderful. This my second part of the question is, does this work, for instance, on bursitis or?
Billy, I sure hope so.
Donna.
Thank you, everyone. Our very eloquently and bravely delivered story of recovery highlighted the sort of ABCs of what you go through when you're a patient who's having difficulty with treatment. There are side effects with everything that you put in your mouth or you receive. So could you address how can a patient or parent who has a child who has illness and is suffering from so many side effects, what is MGH's overarching approach to comprehensive care so that if your thyroid is inflamed or you've gained significant weight from a medication or you're developing diabetes, there are so many other ripple effects. And the shift in movement, if you're working with your psychopharmacologist and an internist or other doctor, it seems to me there's a disconnect in caring for the overall patient. I'm not suggesting MGH specifically, but broadly. So how does one navigate that?
So if I can, no, you can go.
You're the chief.
This is one of the advantages of being in the general hospital. The traditional view that mental illness should be treated in mental hospitals or psychiatric hospitals. Being in a general hospital allows us to work in a team fashion. I can get the endocrinologist, I can get the nephrologist, the cardiologist, for example, in oncology, right? The immune therapies have been a tremendous breakthrough, but they have effects, on the heart, they have effects on the kidneys, etc. So at Mass General, our cancer center really interacts with all the other specialists to optimize the treatment, minimize side effects of these new treatments for cancer. That's what we can do at Mass General. We can do a comprehensive approach, but the psychiatrist cannot operate in isolation. It has to be really part of a much comprehensive team.
So that was the answer of an administrator.
It started out well with the deference.
Because Maurizio's correct. We are in a general hospital, and we have the luxury of working with our colleagues. But Don, I think you were asking a different question in a way, because yes, there can be metabolic side effects, there could be thyroid issues, weight gain associated with some of the medicines that we prescribe. But when we're talking about psychiatric patients who have complex issues where there's a therapist, a neuropsychologist, a behavioral therapist, in addition to a psychopharmacology consultant or treater, what you're really asking, I think, is who quarterbacks. And I don't think we have great models, frankly, for doing that. If you asked what I think we do differently, what I think we try to do is to integrate the care of the providers in a way so that everybody's sort of speaking the same language, and also that gets communicated back in a coherent way to the patient and to the patient's family and loved ones, because I think that type of consistency paves the way to the sort of hope that I think Marlene was talking a little bit about in her remarks. It can be very confusing for patients and very upsetting if she doesn't feel that team is on board in a consistent way.
So we had, mine is historic and is consistent with the administrative response, which is something about the history of our department. Most general hospitals have about 10 to 20% of their inpatient beds as psychiatric beds. So we have a 1,000-bed hospital, so do the math. We would have 100 or 200 beds for psychiatry. We have 24. So necessity is the mother of the invention of this department, which was that we had to learn how to care for our patients, of the physicians, the surgeons on the units in those other beds, and we had to do it in a way that was very efficient. We had to speak, as Lee was saying, in ways that were very clear, as we say inside of our club here, no psychobabble, but ways that were understandable, and to learn it in a very efficient way, to develop relationships with the physicians and surgeons, and it is those relationships which has led our department to be supported, unlike, I think, almost any other department of psychiatry, because as Maurizio alluded, the budgetary challenges based on terrible reimbursement, both for the inpatient units, but for all of the outpatient services, has required great generosity and support by the hospital. And it's because they see the value of the service that's delivered, which is why I'm not worried about our department because of the support we receive. But it is, I think, what Maurizio said and what Lee said, it's that collaboration and the relationships.
John, if I might. So Donna, just one more thing to get very practical. You know, you often need to see teams of people, but it's really hard work to go and see all the different specialists you need to do. And for common problems, you know, you mentioned weight gain. So we've worked with the Department of Medicine to bring a diabetes treatment clinic, treatment program into our schizophrenia program, for example. So at the Freedom Trail Clinic, we have wonderful diabetologists who come over and the diabetic nurse to teach, along with the behavioral therapist, so that people come to the clinic where they're used to coming, but they're getting expert care from other parts of MGH. So that's called reverse integrated care, if you want the babble of it. But people loved it, and they really came, and they had what many of us almost couldn't believe in terms of good outcomes.
No, you know, Eden is absolutely right. The challenge, for example, you know, about 10 days ago, Jennifer came to my office. We met with a family that is, you know, struggling with depression, mild cognitive impairment. So we had the neurologist there. We had Dr. Gatchell there, and the psychopharmacologist. We were all there. But the insurance wasn't cover any of us getting together to see the patient. So that is a fundamental problem that we need to address, because the best care has to be coordinated. And I know it's an administrative response, but I think it's a good response.
Okay, here we go. He won't let it go. Go ahead, Lee. Were you going to say something?
No, I was just going to go to the next question.
Hello. I know that PTSD is a big topic of conversation. Being in a constant state of fight or flight for endless amount of time can have a lot of wear and tear on the body. Is there any new cutting edge kind of forms of therapy that can turn the brain off being in that constant state of fight or flight?
Jerry?
So, well, The most effective treatment for PTSD are a variety of fairly challenging psychotherapies like intense exposure and in vivo re-experiencing and cognitive processing therapies, those sorts of things. But PTSD tends not to travel in pure form, and so it's often complicated by coexisting substance use issues and depression. So treating the PTSD is just one part of it. There are a lot of innovative programs now for trying to understand new ways of treating PTSD because the traditional psychiatric medications haven't been that helpful. The psychotherapies have. We have a very large veterans treatment program at Mass General called the Home Base Program, where we treat many hundreds of patients from the Massachusetts, New England region, but we also bring in from around the country for free, flight included, hotel included, for 2 weeks, for 4-day weekends, veterans from not only around the country, around the world. And they participate in an intensive 2-week program where they get the psychotherapies, they get health behavior inputs, they get treatment of related conditions, and the outcome from something that intensive has been really quite impressive. That said, because of the need for innovation, you are seeing now the DoD looking at some of the new treatments I alluded to, like MDMA-assisted psychotherapy, psilocybin-assisted psychotherapy, are all being tried now in PTSD populations, which reflects the fact that the traditional treatments, even though they're effective, don't treat everybody.
For example, like that cap, that like the top
TMS, transcranial magnetic.
it's like the electrotransfer.
So if you mean, yeah, do you know more about TMS and PTSD?
So it's not an FDA-approved treatment. I think it's still early days in terms of, I think there have been some studies that suggest its efficacy, but it's not a kind of gold standard. But I think there's definitely more research needed in that area because TMS and like different forms of neuromodulations and how we can change brain activity short of inducing a seizure, I think is also a cutting-edge area in psychiatry. And so I think that may be an area of kind of future development.
So yeah, there are some groups that are interested in doing an injection into the stellate ganglion that blocks your body's norepinephrine response, your fight or flight response. So you go through therapy without the re-experiencing of the symptoms, and there's some belief that, or testimonials are very positive outcomes from that as well. So it's a situation where there's so many different options that it's hard for people to know what to do, but I would start with the traditional therapies, which do work.
So we could go, and that was about the fastest 40 minutes that I've been through in a while. We could go, I'm sure, easily for longer. The good news is all of us will be around afterwards, and we are now going to bring up the closers, or the semi-closers for this moment, our hosts and our generous leaders, Michelle and Carol. I personally want to thank all of you for your attention today.